Let's move to case 3. This is a 61-year-old patient who has intermittent epistaxis, facial pain, and nasal stuffiness. Now has some fullness as well as numbness over the inferior orbital region. We do get the pertinent social history that he previously had been employed as a furniture maker. Here are some axial CT images of this patient. Here's the MR examination that was performed subsequent to the CT. Pre and post contrast T1, the post contrast with fat suppression, which we do essentially uniformly in all of our ENT workups. And here finally the coronal post-contrast T1 images with fat suppression. So, to the response system, which statement best describes this lesion? Do you feel the lesion is well-defined and expansile? Do you feel that it demonstrates irregular bone destruction as invasive? Do you feel the mass is confined to the sinonasal cavity? Or do you feel that this is a primary orbital mass that has secondary sinonasal involvement? Please choose your response. That was the biggest softball of all. Very good. I think that's the highest score registered on this system to this point. That is correct. Irregular bone destruction and is an invasive lesion. And again, here shown on a representative axial CT examination, you can appreciate that the lesion has permeated, destroyed, and moved into the nasopharyngeal masticator space from a posterolateral aspect, as well as invading buccal space fat here anteriorly. So a very aggressive lesion with irregular bone destruction. Next response. True facts concerning sinonasal squamous cell carcinoma include: the majority of these lesions arise within or extend to involve the maxillary antrum. Nickel exposure is a strong epidemiologic association. The prognosis relates most to tumor stage as opposed to location, or all of the above. Please choose your response. And the audience response system says, dang, I'm shooting for 100% here. I'm not getting it yet. We'll get it. Indeed, all of the above. And I think probably one of those lessons we all learned when we learned how to take tests is if you see that all of the above, you got to look at it really quickly. It's a reasonable choice. The majority of squamous cell carcinoma of the sinonasal cavity does involve the maxillary antrum, either primarily or as secondary extension. Nickel exposure, very interestingly, is a very strong epidemiologic association with squamous cell carcinoma. And unfortunately, the prognosis is related to tumor stage, and unfortunately, most of these lesions present at an advanced stage because very early they may appear the same clinical symptomatology as chronic sinus disease. So here's that representative axial CT exam again as well, and if I had you turn away from the board and describe this lesion to you, I'd say there's an irregular destructive lesion involving the maxillary antrum, involving buccal space fat, as well as extending posteriorly and laterally to involve the nasopharyngeal masticator space. Looks relatively preserved from the muscles of mastication, but I have to be very concerned about the findings within the pterygopalatine fossa here where I have obliteration of normal fat. So why is this lesion squamous cell carcinoma? Again, the irregular bone destruction is paramount, and that's going to be the most likely diagnosis that we will say, and we'll be right more times than we're not when we see that irregular bone change. The maxillary sinus origin is common, and historical elements may contribute. And that's one of the times that I actually am very interested in looking at patients' related history in our electronic medical record. Furniture making, radium, and solvent exposures are likely significant in evaluating numbers of these patients. Nickel exposure, however, as I stated, is probably the single most important etiologic factor. We see a lot of patients in our region who participate in the furniture industry, and there's some indication that hardwood dust exposure is important. Here's another case of squamous cell carcinoma. This is a more advanced lesion, that low signal intensity on T2 again, but irregularly destructive, as noted here on the post-contrast T1 images, infiltrating buccal space fat. And here's the largest one I could find because I think it's important when you go to meetings like this to see the biggest and baddest. This is the worst one I've ever seen. Very large lesion on the maxillary antrum with obvious facial deformity, irregular bone destruction, and almost a cystic necrotic appearance centrally. So let's move to case 4. This